see a few people are coming in. We'll just wait a few minutes to give folks time to join before we officially start. So just sit tight for a few minutes. Thanks. Thanks to those of you who have already joined. We're just going to start in a minute or two once a few more people log in. Hey, it's 7:03, so I want to be respectful of everybody's time who's logged in and has joined us. We thank you so much for joining us for our series. This is the Mind Matters series, part of the Department of Psychiatry's series on addiction. And today, Dr. Coleman is here to discuss medications for addiction and relapse prevention. And I'm Ann Fernandez. I'm an associate professor and director of clinical programming at UMATS. I'm also a practicing clinical psychologist here at the UMATS clinic. UMATS, for those of you who don't know, is located at the Rachel Upjohn building off of Plymouth Road in Ann Arbor and is part of the Addiction Center in the Department of Psychiatry. A core part of our mission at UMATS is to deliver care that is directly informed by research. And with this speaker series, we're hoping to share the latest research on addiction and give research-informed information and help and talk about how research and care can help deal with problems related to substance use when they arise, what makes substance use problems continue, and how to break out of the cycle of problematic substance use. We're aiming to deliver this series quarterly, with each talk focusing on different aspects of addiction and its treatment. Tonight joining us is Dr. George Cameron Coleman, and he's a clinical assistant professor in the Department of Psychiatry. He's a practicing physician in addiction medicine with UMATS and provides medication management and other clinical care to patients with substance use disorders. Dr. Coleman received his MD from the University of Virginia. He completed his internship in internal medicine and residency in preventive medicine and his fellowship in addiction medicine at the University of North Carolina, Chapel Hill. He also completed a master's degree in health informatics at the University of North Carolina. Outside of work, Dr. Coleman enjoys reading nonfiction, hiking and trail running, particularly in the Blue Ridge Mountains. So maybe you haven't gotten to do too much of that lately. Well, pardon me, the cleaners are going by. Watching ACC basketball and playing golf. So Dr. Coleman, thank you for joining us. And before we begin, I wanted to mention that questions can be submitted by clicking on the Q&A button at the bottom of the screen. You can feel free to put those up during Dr. Coleman's talk too, and we can either have them during the talk or we can address them after. There's an option to submit questions anonymously. After Dr. Coleman's discussion, we'll do our best to answer as many questions as possible. And please note, you can put general questions, you can have questions about clinical care, but just refrain from asking questions about specific patients or yourself if you're a patient at UMATS. We just can't address those questions in this forum. So your clinician, if you are a patient or have a loved one that's a patient, can help with those questions during the clinical care. So, and a recording will be available and emailed to everyone as soon as possible after tonight's talk. And so now I'll turn it over to Dr. Coleman. Thank you so much.
Thank you, Dr. Fernandez, and welcome everybody. Let me pull my slides up here. As Dr. Fernandez said, I'm an addiction medicine physician here at UMATS, and my alma mater, University of Virginia, was up in town playing Michigan and men's basketball a few weeks ago, and that was a nail biter. But I'm happy to be with all of you this evening to talk about medications for addiction treatment and relapse prevention. And one point that I wanted to make from the get-go here is that medically, we really view addiction and substance use disorders as chronic relapsing conditions. Many of you may have chronic medical problems yourself. You may have family members that have physical health conditions such as asthma, congestive heart failure, multiple sclerosis. All of these conditions are relapsing conditions. They're prone to acute flares, acute exacerbations from time to time. And it's important to recognize that substance use disorders are no different. So tonight, we will review some of the medications that we have in our arsenal for addiction treatment to help patients with substance use disorders reduce their risk of relapse. For starters, some of you may have heard this acronym, MAT, which stands for Medication Assisted Treatment. This refers to the idea of using medications in combination with counseling for comprehensive treatment of addiction and substance use disorders. You may have seen this online, you may have seen MAT clinics, or you may have seen local clinics that advertise that they do MAT. Now, some folks in the addiction treatment community have pointed out that medications can be treatment in and of themselves and should not be viewed as secondary to counseling or therapy or other modalities of treatment. So because of this, some treatment providers will refer to this acronym MAT as medications for addiction treatment rather than medication-assisted treatment. Let's begin with a review of medications that we have for the treatment of alcohol addiction or alcohol use disorder. And really, there are 3 FDA-approved medications, which are naltrexone, acamprosate, and disulfiram. Like all medications we'll review this evening, these medications don't provide a cure for the underlying disorder or the underlying addiction itself, but they can be a really effective tool for a patient who's participating in a comprehensive treatment program. So for starters, naltrexone is really what I consider to be the first line medication for patients with alcohol addiction or alcohol use disorder. It was FDA approved for this in the 1990s, I think 1994. And it's actually an opioid blocker. So we'll talk about naltrexone again later this evening when we talk about treatment options for patients with opioid use disorder. But this medication, an opioid blocker, can actually work in the brain for patients with alcohol addiction by making alcohol less pleasurable. So it works by blocking the euphoric effects or the rewarding effects that patients experience when they drink alcohol. It doesn't block you from becoming intoxicated, but it is designed to uncouple that pleasure. So many patients will say that they start taking this medication and they sort of lose the taste for alcohol, or they don't experience the same cravings, the same urges. They're not so preoccupied thinking about drinking. What we like about this medication is that it's been proven to be effective for patients, regardless of whether their goal is to stop drinking altogether and to be sober, or whether their goal is to reduce their drinking and drink less. In both cases, it can be effective by reducing cravings or urges for alcohol. The studies show us that naltrexone reduces relapse in patients whose goal is sobriety by about a third. So it's fairly significantly effective at the population level. The dosing of this medication is pretty easy and pretty straightforward. It's one tablet, 50 milligrams once a day. There's no need to gradually titrate the dose up, or if you decide to discontinue this medication, you don't need to titrate the dose down. You can just stop it. Things to remember about naltrexone are, because it is an opioid blocker, number one, you can't take it if you're currently taking opioids. Number two, you can't take it if you've recently taken opioids or been exposed to opioids in the last 7 days. And number three, if you may need opioids in the future, say for a surgery, a dental procedure, or maybe you break your ankle and you wind up in the emergency room and they need to give you a shot of morphine, you'll just need to let your doctors know. This medication may not be an option for patients with severe advanced liver disease, but in almost all patients, it can be a safe option. In terms of side effects, we typically see that about 2 out of every 10 patients who start naltrexone may experience mild side effects that typically include headache, nausea, reduced appetite, fatigue. But more often than not, those sorts of side effects will resolve in the first week or two. You'll see 2 examples of naltrexone on the screen here. What we use most often for patients with alcohol use disorder is the oral tablet, the pill down in the bottom right. But naltrexone is also available as a shot and an injection that you can get once a month, and that goes by the brand name Vivitrol. Number 2, in terms of medications that is FDA approved for the treatment of alcohol addiction, is acamprosate, or the brand name is Cambrol. This is really used for people who have stopped drinking and their goal is to avoid returning to drinking. So unlike naltrexone, where we can use it even in patients whose goal is just to reduce their drinking, acamprosate is most effective in patients whose goal is, or who are ready to commit to total sobriety. It's not an opioid blocker. It works a little differently in the brain, but it similarly has the effect of reducing cravings. And it can also diminish what we refer to as the protracted alcohol withdrawal symptoms that can linger in some patients for several weeks after they stop drinking. Things like depressed mood, irritability, anxiety, and therefore this medication can help patients break the cycle of negative reinforcement if they're inclined to go back to drinking to mitigate some of those protracted withdrawal symptoms. The studies show us that this medication has never really been effective in patients whose goal is just to reduce their drinking, but we know that it works in patients whose goal is total sobriety. This medication was initially studied in Europe, and it's used more often in Europe than we use it here. But some of the initial European studies of this medication showed that about 20% of patients were able to remain sober at 1 year taking this medication, as compared to just 10% who took a placebo. Some of the US studies of acamprosate showed mixed results. But the studies have definitely shown that patients who are really motivated and very clear that their goal is total sobriety, this medication may be an effective option for those folks. Acamprosate is a medication that we don't start until you've stopped drinking and you've successfully gone through the acute detox window. So typically we'll start this medication maybe day 4, day 5 after you've stopped drinking. And in terms of dosing, it actually is 2 tablets that you take 3 times a day. So some folks feel that that dosing requirement and having to remember to take 2 pills 3 times a day is inconvenient or a headache. Acamprosate tends to have slightly more side effects than the first medication we talked about, naltrexone, but typically the side effects include things like lightheadedness, dizziness, upset stomach, uh, loss of appetite. This medication is cleared by the kidneys, so it may not be an option for folks with severe kidney disease, and it's a reason that we would monitor kidney function for patients who are taking this medication. But aside from that, it's very safe, and it's not a controlled substance. The third medication that we have that's FDA approved for the treatment of alcohol addiction is disulfiram. Many of you may be familiar with the brand name for this, which is Antabuse. This one's been around since the 1940s, and this is the medication that interferes with the way that your body metabolizes or clears alcohol from out of your system. So this is the medicine where if you take the medicine and then you drink alcohol, it makes you very sick. So it is designed to work as a deterrent. Because of that, patients must be very clear that their goal is total sobriety. Their goal must be to abstain from alcohol altogether, and they must have already stopped drinking. We rarely use this medication at all these days. I think if I have 100 patients in my clinic who are on medication for alcohol use disorder, maybe just 1 or 2 are on disulfiram. And that's for a couple of reasons. Number one, if you do drink alcohol and trigger the reaction of making yourself violently ill, that can make you violently ill. And I've seen patients who needed to go to the emergency room because of that. So we avoid this medication in any patients with underlying liver disease, heart disease, or lung disease. Even if you don't drink alcohol and trigger that reaction, this medication has some nastier side effects, things like drowsiness, reduction in libido, headache, and even the strange metallic taste that some patients will describe. So it can be an option for a small subset of folks whose goal is to reduce their drinking, but the studies have actually not demonstrated nearly as much effectiveness in terms of helping people avoid returning to use with alcohol with disulfiram as compared to the first medications that we talked about. And typically the studies that did show some benefit were designed where patients would have family members, spouses, significant others involved in their treatment to help them remain accountable and remember to take this medication every day. So we'll switch gears here. We'll transition from talking about alcohol addiction to opioid addiction and medications for opioid use disorder. There are 3. They are buprenorphine, methadone, and naltrexone. And these medications are options for the treatment of opioid addiction or opioid use disorder, regardless of whether a patient is using heroin or morphine or fentanyl or oxycodone or hydrocodone, you name it. One thing to keep in mind here is that when we talk about cravings or urges, and this is true for all forms of addiction, but it's particularly true for patients with opioid use disorder, we're not talking about just the fleeting little thought that, hey, maybe a piece of chocolate wouldn't be bad right now. In patients with addiction, but particularly opioid use disorder, cravings are these very intense, overpowering desires to use a substance to escape, to reduce pain, to reduce anxiety, or to feel pleasure. And the intensity of these cravings can significantly affect someone's decision-making and their judgment. The second thing to keep in mind is that patients who have opioid use disorder, if they stop using opioids all of a sudden, abruptly, and they go into what we refer as opioid withdrawal, they feel miserable. Physically, mentally, it is a highly, highly unpleasant state to be in acute opioid withdrawal. And patients who are in that condition will do almost anything to alleviate the withdrawal and to feel better. So keep these ideas in mind, cravings and withdrawal, because that is what we target with our medication options. So the first medication is buprenorphine, and buprenorphine is what is called a partial opioid or a partial agonist. It binds to the same opioid receptors in the brain, just like morphine or oxycodone or heroin, but it works a little bit differently, and it has what we refer to as a ceiling effect. So you can think of the opioid receptor in the brain as the burner on a stove. Full opioids, things like morphine, heroin, oxycodone, they can turn the heat on that burner all the way up to high, 10 out of 10. Patients like that because that's what provides the sense of pain relief or even euphoria or intoxication. But that's also what can lead potentially to overdose and death when you crank that heat all the way up. So unlike those full opioids, buprenorphine still turns the heat on the stove. It still binds to the opioid receptor, but it never goes beyond like low medium heat. We're talking maybe 3 or 4 or so on the dial. Because of that, it still activates the opioid receptors, and therefore buprenorphine can eliminate or greatly reduce cravings for opioids. It can eliminate or greatly reduce withdrawal symptoms without having the dangerous potential of causing sedation, causing a sense of high or intoxication or euphoria, or causing difficulty breathing or overdose. So that is the reason that buprenorphine is designed in that manner. Buprenorphine comes in a number of different formulations. The vast majority of patients who take buprenorphine will take the brand formulation, which is called Suboxone. Suboxone is available as a film or a tablet that dissolves in the mouth under the tongue. But buprenorphine is also available in other formulations, including a different brand, a different pharmaceutical manufacturer called Zubsolv, an alternative called Subutex, as well as a long-acting injection that you can get under the skin once a month or so, and that's called Sublocade. So that may be an option for patients who prefer not to have to take a medication every day or multiple times a day. Number 2 is methadone. So methadone is a full opioid. Methadone can turn the burner on the stove all the way up to 10. It's a long-acting opioid. So typically it lasts in the body for 24 to 30 hours. And because it is a full opioid, it can target and eliminate opioid cravings and opioid withdrawal. It's designed to be administered or to be dosed once a day, typically in the morning, typically as a liquid. But the thing to be aware of with methadone is that I can't write a prescription for my patient with opioid use disorder to go pick up methadone from their pharmacy. I can write a prescription for patients to use low-dose methadone for pain, but if I'm treating opioid addiction, opioid use disorder, typically the doses of methadone that we use are much higher, and we can't write prescriptions for that. Patients who are treated with methadone do so at a methadone specialty clinic where the methadone is dispensed typically once a day. So access to methadone treatment can be a little trickier for some patients. Again, you have to go in person every day to a clinic to receive your daily dose. How well do these medications work? How effective are they at helping folks avoid relapse? Well, we know without a doubt, based on multiple studies, that these medications are highly effective, that patients with opioid use disorder treated with these medications are less likely to overdose, less likely to die, less likely to relapse or return to using, less likely to be arrested, incarcerated, less likely to acquire infections related to IV drug use like HIV or hepatitis C. So the list of benefits goes on and on with these medications. But what I tell patients is take 10 patients that have opioid addiction or opioid use disorder, and they're using either opioid pills, heroin, fentanyl every day. If you take all of those 10 patients, you admit them to the hospital or to a rehab facility, you treat their withdrawal so they stop using, and then you discharge them, then what we know based on a number of studies is that between 30 and 90 days, 9 out of 10 of those patients will return to using opioids. We know that that's the nature of opioid addiction. Relapse rates are about 90%. In contrast, say you take 10 other patients who have the same opioid addiction, you admit them to the hospital or a rehab facility, you treat their withdrawal, and then you start them on maintenance medication with buprenorphine or methadone. then over the same time frame, 30 to 90 days, what we see is a reduction in the number of folks who will relapse from 9 out of 10 on no treatment down to about 4 or 5 out of 10 with these medications. So that's a significant reduction. I mean, a 50% reduction in the risk of returning to using or relapsing. But obviously, it's not a silver bullet. These medications work because they're really effective at managing cravings and withdrawal symptoms, which allows patients to get their life back together, to feel normal physically and mentally, and to devote their energy toward other aspects of recovery and sobriety. So we know that if we don't address cravings, if we don't address withdrawal symptoms, if we don't treat those things, then those are significant risk factors that will increase a patient's likelihood of relapsing. Naltrexone, as we mentioned earlier, is an opioid blocker. So naltrexone doesn't turn the burner on the stove on at all. In fact, it blocks anything else from turning the heat on the stove. So the benefits of naltrexone are that it's not a controlled substance. If you decide to stop taking it, you're not going to have any withdrawal symptoms from the naltrexone. But the downsides are that because it doesn't turn the stove on, it doesn't address cravings and it doesn't address withdrawal nearly as much as buprenorphine and methadone. Naltrexone, when we use it for patients with opioid use disorder, we use the long-acting injection formulation, which is called Vivitrol. That's the brand name. Some of the initial studies, when they compared Vivitrol or extended release naltrexone with buprenorphine or methadone, suggested that rates of relapse were about the same, but newer, more recent studies have shown different results, especially for more high-risk populations, such as patients who are leaving the criminal justice system, leaving long-term care facilities, returning to use or rates of relapse tend to be a little higher with naltrexone as compared with buprenorphine or methadone. But it still can be a very reasonable option for patients who may not have co-occurring pain, who may not have had difficulties with relapse in the past, who may be brand new to treatment. So it's an important option that all patients learn about. We'll switch gears briefly and we'll transition to cannabis addiction or cannabis use disorder. So this is patients who might smoke flower cannabis every day or use other THC or CBD products. Really, thus far, the most promising medication that we've identified for the treatment of cannabis addiction is called N-acetylcysteine or NAC. This is a supplement. It's essentially an amino acid that you can get over the counter. And it's been shown to be really effective in animal studies, particularly with cannabis addiction. The human studies of NAC or N-acetylcysteine showed that it worked pretty well in adolescents, but it worked less well in adults. NAC is generally very safe, very well tolerated. There are essentially no side effects. The biggest consideration with NAC is really that some pharmacies just don't carry it in stock. So even though patients can buy it over the counter, sometimes we have to send a prescription and they may need to hunt down a different pharmacy to see who has it on their formulary. Switching gears again to talk about patients with stimulant addiction or stimulant use disorder. This refers to patients who have addiction to cocaine, amphetamines, or methamphetamine. Long story short here, we don't have any FDA-approved medications for the treatment of stimulant addiction. A lot of medications have been studied, but none of the studies have shown significant benefit in terms of reducing rates of relapse, reducing rates of stimulant use, despite a number of different medications that have been tried. Because of this, really the mainstay of treatment for stimulant addiction is the kitchen sink, a combination of everything else that we have in our toolkit. So individual therapy, family therapy, potentially various other types of behavioral therapy, treatment of co-occurring mental health conditions, 12-step programs, and other treatment modalities. Lastly, let's talk a little bit about nicotine and tobacco. And the treatment options that we'll review here are options regardless of what form of nicotine or tobacco a patient is using. So they may be smoking cigarettes, using a nicotine vape, using chewing tobacco, smoking cigars. We know that nicotine is highly addictive. And we also know that many patients who use tobacco products really want to quit. And we also know that if you take 100 patients who were using nicotine or tobacco, smoking cigarettes every day, and they all just try to stop cold turkey, the number that will be successful is 2 or 3. That doesn't say anything about the willpower or the determination of these folks. That just tells us that the nature of nicotine addiction is that 97 to 98% of folks will relapse or return to using without some form of treatment. So the medications that we use for nicotine or tobacco treatment work in the area of the brain that nicotine is active. They work by blocking or reducing the effects of nicotine in the brain and also activating some of the nicotine receptors in the brain to target cravings for nicotine products. We have a lot of tools in our toolbox when it comes to tobacco treatments. You're probably all very familiar with the idea of nicotine replacement therapy. So these are things like the nicotine patches that you've seen commercials for, or you've seen available over the counter in CVS or Walgreens. Nicotine patches are long-acting products that deliver some nicotine to your system every day. We often use these in conjunction with short-acting nicotine replacement, whether that's the gum, like Nicorette, or the lozenge. The dosing of nicotine replacement is really critical. And I won't get into the weeds here, but most people who tell me they've tried the patches, tried the gum, and it didn't work for them, that's because they were using too low a dose. We use nicotine replacement often in patients who are hospitalized or maybe recovering from surgery. And we know that nicotine replacement is much more effective than just stopping cold turkey. If you take 100 patients who want to stop smoking or using tobacco, then with nicotine replacement, we can bump that number from 2 or 3 out of 100 up to 15 or 20. So a modest improvement. Other treatment options that we have for nicotine or tobacco include medications, prescription medications such as bupropion, which goes by the brand name Zyban or Wellbutrin, as well as varenicline, which goes by the brand name Chantix. So with these, we can bump that success rate up even higher. With bupropion, we typically see 20 or 25 out of 100 patients who are able to be successful. And with varenicline or Chantix, we see somewhere in the neighborhood of 30 to 40 patients out of 100 who are able to be successful. And the numbers that I just gave you, that refers to the first time starting any treatment for nicotine or tobacco. We often will use combinations of these things, and it's not uncommon to take or to find patients where it takes them 5, 10, 15 attempts to quit smoking or to stop chewing tobacco before they're able to successfully make that change. So patience and persistence is part of treatment and part of what we talk about when we're counseling our patients about these medication options. That was a whirlwind tour of the medications that we have available for addiction treatments at our clinic, UMATS, University of Michigan Addiction Treatment Services. We offer more than just medication, but we do specialize in medical evaluation, consultation, and management for patients whose primary problem is addiction or a substance use disorder. We're a multidisciplinary clinic, so we have addiction medicine providers like myself, we have addiction psychiatrists and other psychiatry trainees, psychiatry residents. We have nurses, clinical social workers, psychologists, so we all work as a comprehensive team to develop a treatment plan for our patients. We prescribe medications for patients to address the addiction, just like the medications we've reviewed tonight, as well as other medications for co-occurring psychiatric illness, like depression or anxiety. We don't believe that all patients should be on medication. We're not a pill-pushing clinic. We don't believe that all patients need medications, but we believe strongly that all patients should be aware of all the options, and we want to work with our patients one-on-one to develop an individualized plan for them. For many of our patients, medication can be an effective tool in addiction treatment. Who can come to UMATS? Who can come receive care at our clinic? We welcome all people who are interested in understanding their substance use, maybe folks who are interested in changing their substance use, maybe folks who know they have addiction. They may have tried addiction treatment in the past, they may have struggled, they may have recently relapsed. We welcome all patients. We see adolescents all the way up through older adults, and we accept most private insurance plans as well as Medicare. As I mentioned, we prescribe essentially all of the medications, if we deem it as appropriate, that we've reviewed tonight, with the exception of methadone for patients with opioid use disorder. And as we mentioned, methadone is the sort of thing where if that's the option that makes the most sense for a patient with opioid use disorder, it can only be dispensed at a methadone clinic or a specialty clinic. But we commonly will help patients link to methadone clinics in our area. And with regard to the other medications that we talked about, buprenorphine, naltrexone, nicotine replacement, many of these medications can also be prescribed by primary care providers, family medicine doctors. And there have been a number of recent laws that actually made it easier to prescribe buprenorphine so that more people have access to buprenorphine. So often we'll help patients who are maybe new to opioid use disorder treatment, who are interested in getting stabilized on buprenorphine. Once we've worked with them for a period of time, oftentimes we can transition them back to their primary care doctor, who can then take over the prescription for Suboxone. We offer outpatient addiction care, as I said, for adolescents and adults. And in addition to all the medications that we've reviewed tonight, this slide details the non-medication treatment modalities that we provide. So we do behavioral treatment, we do cognitive behavioral therapy, we do motivational interviewing, we help patients connect with mutual help groups in the community. We offer a number of dedicated group therapy programs through our clinic that specialize in providing education and helping patients develop relapse prevention plans for themselves. We also offer an intensive outpatient program that may be appropriate for patients who are relatively new to sobriety or new to recovery. And that involves meeting in our clinic 3 days a week for a little bit more intensive treatment. We always recommend patients who might be interested in learning more about addiction treatment, talk it over with a provider that you trust. If that's your primary care provider, if that's your mental health provider, if those providers are able to refer you to our clinic, that's one way to get in the door. If you're interested in referring yourself, you can find our contact information on our website. But we offer a mix of in-person care and visits for patients who are local and would like to come work with us one-on-one in clinic. We also offer telehealth visits, and we're able to see patients across the state of Michigan. And that's been something that has been a priority for us since COVID. So that was a whirlwind tour. Thank you so much for your attention. I will end the presentation now, and we'll be happy to address any questions that you may have.
Okay, thanks so much, Dr. Coleman. So we'll take questions. So if people have questions that they want to put in the Q&A, feel free to do that as we go. We have a few to get us started. So first off, someone is wondering if there is a risk for naltrexone if a patient does still binge on alcohol while on the medication.
That's a good question. So just to clarify, is this a question about, can you get in any trouble if you're prescribed naltrexone and then you drink while you take it?
Yeah, I think they're saying if like the person is taking it, so actively taking the medication and then binges, so like heavy alcohol use while on the medication. Yeah.
Great question. And the answer is very rarely. So the one consideration that I didn't mention about naltrexone is that it may not be an option for our patients with severe advanced liver disease because of the way that it's cleared from the body by the liver. We know that patients who are maybe in the middle of a binge episode can cause some liver inflammation and can damage their liver. But the risk of liver toxicity with naltrexone itself is essentially minimal. There used to be a black box warning on naltrexone many years ago because of concerns for liver damage, but that's because they used to prescribe it at much higher doses than we use now. Nowadays, one tablet, 50 milligrams once a day. At that dose, it's rarely a concern for liver function, even if folks sort of have a relapse and return to drinking heavily. What we know is that in the long run, what's more detrimental to their liver health is ongoing chronic heavy alcohol use. So we monitor naltrexone, especially in patients who say, hey, I had a slip, I had a lapse, I drank a lot. Sometimes we will monitor liver numbers. And for a subset of patients who see a liver specialist or a hepatologist, we may consider making an adjustment with the naltrexone, lowering the dose. But 99 times out of 100, you're not going to cause any extra harm for yourself if you're prescribed naltrexone and then you drink heavily.
Great, thanks so much. And I think this is a follow-up question related to naltrexone is and it says, asking if it can be given, I'm assuming prescribed in Canada, which I think is yes, but.
That's a good question, and I don't know the answer to that. I would refer you to your local treatment provider there in Canada. My assumption is yes, it probably is readily available, but I don't have a medical license in Canada, so that's actually never something that's come up for me.
Yeah, I guess we're right over the border. So, yeah, I also assume yes, but I don't know for sure either.
And I'll mention I had one other consideration for naltrexone. So it's designed to be a once a day medication. Like all medications, your blood pressure pills, your antidepressants, it's most effective if you take it consistently. Some patients will take it first thing in the morning. Other folks will take it before bed. Some folks like to take it maybe 4 or 5 p.m., right around that happy hour time where their cravings or their urges are strongest. But we know that naltrexone may also be beneficial if you just take it as needed. So some patients might just keep it available in case they're going to a wedding or a social function, or if they anticipate that they will be in an environment where alcohol is there and they know they might have stronger cravings, they like to have it and just use it as needed. We know that it works in that case, even if you don't take it every day.
Cool. I actually did not know that. I learned something. And for candidates for medications who are committed to sobriety, can naltrexone be combined with this person saying option 2 or 3? So I think that's the antabuse and acamprosate for treating alcohol addiction.
Great question. The answer generally is yes. We don't see it very often, but I have personally had a handful of patients with really severe alcohol use disorder, a number of relapses, a really tough time maintaining sobriety. And sometimes in those cases, we will combine, for instance, oral naltrexone with oral acamprosate. So that doesn't happen often, and it would have to be a special type of patient, but that may be a potential option. What I would not recommend would be to use both formulations of naltrexone, the oral once a day tablet, as well as the injection Vivitrol once a month. You typically don't get any extra bang from your buck if you're doing that.
Thank you. And how difficult is it to stop using these medications? So I think the answer is probably going to vary by the medication, but maybe if you could just speak to difficulty in stopping them.
Great question. And absolutely, it really varies. It depends on the medication. So for things like naltrexone, for instance, for alcohol use disorder or acamprosate, if you are taking those medications for a period of time, you feel like things are better, you no longer need them, you no longer have the cravings, or if you don't feel like they help you, you can just stop them. You don't have to gradually taper down your dose. The most problematic medications, or the ones where we have to put the most thought into it in terms of discontinuation, would be buprenorphine and methadone. And that's because buprenorphine is a partial opioid, methadone is a full opioid. So your body will develop a dependence to those. And if you were to stop those abruptly, you would experience the same opioid withdrawal as if you were using heroin or morphine. Patients will say that the withdrawal may feel a little bit different, but that still is a risk. Because of that, for buprenorphine and methadone, if a patient really wants to stop or has a reason to stop, then we like to have as much time as possible to gradually taper the dose down. But for the remainder of the medications, with the exception of bupropion, which is an antidepressant and can cause some mild withdrawal symptoms, most of the others that we talked about can just be stopped. Obviously, I would not recommend making the decision for yourself to stop your medications. I would always encourage you to discuss with your treatment provider, but there's no safety risk in abruptly stopping something like um, uh, Chantix, for instance. One other caveat, though, would be patients who have opioid use disorder and are on Vivitrol. So naltrexone, the opioid blocker, the injection Vivitrol. What we know is that because that's an opioid blocker, if patients are not actively using opioids, their tolerance will go down. And we see sometimes patients who have come into the clinic every month, they're getting their Vivitrol injections. And then if we stop hearing from them, if they stop showing up, if they stop receiving their medications, and then all of a sudden they relapse and return to using with opioids, because their tolerance is so much lower, they are at much higher risk of overdose and death with returning to use with opioids. So that is a special consideration for patients who are thinking about stopping Vivitrol.
Okay, thank you. So one thought I just had around naltrexone that I think you touched on naltrexone, but also buprenorphine, is the increased accessibility in the United States, and maybe in Canada as well. But how some of the laws have changed such that accessing some of these medications you can do through your primary care provider. So I think sometimes it's hard for people, like, sometimes it's easier to see primary care to begin a conversation than
Sure.
try to get into a specialty clinic, which also sometimes have a wait list.
Sure.
So I think that was something that was just coming to mind to stress, that there are a lot of pathways to find out more information.
There are a lot of pathways. That's a great point. Suboxone or buprenorphine, primary care providers can prescribe it if they've done special training. So you need a special waiver on your license to prescribe it. But as I mentioned, there are a lot of legal changes that have been made and that have been proposed to reduce those barriers for prescribers. So if you're interested in starting a medication like Suboxone, check with your primary care to see whether they prescribe it. Oftentimes there might be one or two providers in a clinic that prescribes it. But if not, there are a number of websites where you can find providers in your community. And a tangential thought along the idea of expanding access to this treatment is that was one of the priorities for the Affordable Care Act, is that it did make substance use disorder treatment a covered expense. And so patients who are on federal health insurance like Medicare, and oftentimes many private health plans as well, will cover and must cover these medications.
Great. So someone is wondering about NAC, the cannabis supplement that can help with cannabis use. They're saying that they got some at Whole Foods that's 500 milligrams, wondering about quitting cannabis and if you need a pharmaceutical grade or if like something through a grocery store kind of chain would be sufficient.
Sure, that's a great question. So whether you buy the NAC from Whole Foods or you get it from CVS over the counter, or whether I send a prescription for it, it's the same. Typically, it's the same supplement. The dose matters. So the studies that showed some benefits with this medication, again, and we saw the most benefit in younger populations, adolescents. The dose is 1,200 milligrams twice a day. So typically, it's 600 milligram tablets or capsules twice a day. That might be a little bit tricky to get to if you have 500 milligram capsules from Whole Foods, but the dose does matter.
Thank you. And then someone's wondering if there's a medication to reduce cocaine cravings.
Yeah, great question. I wish there was. Unfortunately, no. There have been some studies that showed potential benefit with some medications in patients with stimulant addiction, more so methamphetamine than cocaine. But those are highly specialized subpopulations, and we don't really generalize those results to the public. Um, a lot of medications have been tried for patients with cocaine addiction, even the stimulants, things like Adderall, with the idea being, could you substitute one stimulant for another? Would that lower cravings? And the answer is no. The answer is, unfortunately, none of the studies showed any benefits. And that's something that our neuroscience colleagues are working hard on. If they could develop a medication that was proven to be effective for cocaine or methamphetamine addiction, that would be a game changer for that population. Because right now we just don't have medications for those folks, unfortunately.
Thank you. And how about for MAT, how long you should take it for? Is it a lifetime, something you take for your whole life, or is it a period of time?
Yeah, great question. This comes up often in patients, particularly folks who are receiving buprenorphine for opioid use disorder. So I'll frame my answer to that population, and then if participants have another question, then please ask to clarify. But long story short, in terms of how long should we continue medication like buprenorphine for opioid addiction, the answer is we don't really know, because we don't have long-term studies that have compared patients who stop medication or taper down on their medication versus stay on it for life. The general consensus is that opioid addiction, like all substance use disorders, are chronic relapsing illnesses. So if patients have achieved some degree of stability with medication like buprenorphine, if it ain't broke, don't fix it. Continue on it for as long as it is working. I personally have had patients with opioid addiction who have been on Suboxone for 20 years. I've had patients who have been on it that long and intend to stay on it the rest of their life. I have patients who have been on it 5, 10, 15, 20 years and may want to gradually taper down. And we take an individualized approach to that. We talk about the potential risks and benefits. If we do taper, we go slowly. Many patients find that they may be able to gradually reduce their dose of something like Suboxone. Some patients are able to come all the way off and they feel good. Other patients reduce their dose and they don't feel so good. They feel those cravings reemerge, and that scares them. I will say that for some of our sickest patients with opioid use disorder, folks who have bad medical complications, for instance, from injection drug use, who have bad skin and soft tissue infections, infections in the heart valves and the lining of their heart, maybe folks that have need one or more surgeries to treat those infections, we recommend staying on medications like buprenorphine or methadone really for life, because a relapse could be life-threatening in that case, especially for folks that we see at the hospital who have had multiple heart valve replacement surgeries. So yeah, the answer really is it depends. Talk with your doctor. There are risks and benefits, and if you really are interested in trying to taper off, we encourage you to do so when the rest of your house is in order, so to speak. You've got a good recovery environment, you've got a strong support system, you've had a long period of stability, and go slow, taper slowly.
And there was a follow-up clarifying question about NAC, how you had mentioned 1,200 milligrams per day. To clarify, if you had said 2 times a day or once a day. I think you said 2 times, but
Yes, 1,200 milligrams twice a day. That's the dosing of that medication that they used in the studies. So that's why we use it. Individual patients may feel like it works for them if they take it once a day, but we recommend 1,200 milligrams twice a day for cannabis.
okay. And then why is so Matt? I've said Matt, but that stands for medication assisted treatment. And as Dr. Coleman said, sometimes people say medications for opioid use disorder or medications for alcohol use disorder. So sometimes we say all these different terms. I just wanted to make sure I was being clear. But why are these medications so controversial in the recovery community?
Yeah, that's a great question. So buprenorphine is not nearly as old of a treatment as something like antabuse, for instance. Buprenorphine has only been around since the late 90s, early 2000s or thereabouts. And so there's quite a bit of stigma from older individuals in the recovery community who don't understand it, or maybe folks who think that you're using a partial opioid, or in the case of methadone, you're using a full opioid. How is that not just substituting one drug for another? And the answer is these are treatments that have been studied, that are prescribed and overseen by a physician, and we know how they work. In the same way that if your relative has diabetes and her pancreas stops producing insulin, um, we give her insulin replacement. I mean, we treat the diabetes with insulin. So we know that these medications are effective treatments, even though it is a common perception that you're just substituting one thing for another. The proof is in the pudding, though. I mean, what we know is that these medications greatly reduce the risk of overdose death. They greatly reduce the risk of relapse, and they are more effective than willpower alone or than no medication. So there are some schools of thought that say the only way you can do this is by yourself. You need to overcome this. And what we know is that if you add medication, you're much more likely to be successful.
Yeah, I think maybe you can speak to this, but for certain addictions, that's more true than others. Like the opioid use disorders in particular, when they've studied psychotherapy versus medication, psychotherapy alone isn't actually super effective without medications to supplement. Well, with alcohol use disorder, I think the evidence shows that both are good, but psychotherapy can be as effective as medications.
And that's one of the really rewarding aspects of working in addiction treatment. We've got medications and treatments that work really well, and they can change the trajectory of a patient's life. I mean, I've seen patients who have felt like they've been at rock bottom. They're in total despair. They're using relapse after relapse. Maybe they're homeless. Maybe they have recently gotten divorced or lost their job. And if you start them on medication, their life can dramatically change in a short period. I mean, several months. And so we know that that effect is possible. Another thing that I will say, if I'm counseling patients who are maybe considering buprenorphine, is that we tend to recommend you commit to staying on this medication for at least as many years as you were using whatever it was you were using. So if you'd been using heroin every day for 4 years, and pills before that, then just commit to staying on buprenorphine for at least that long, because it can take that long for some of the chronic changes in the brain to rewire. We know that chronic substance use, particularly chronic opioid use, causes a lot of changes in the brain. And so that's the reason that we don't recommend using medication like Suboxone for a month or 6 weeks or 6 months, because treatment, when extended, is more likely to be successful.
And one last question, and then we'll wrap up. Someone is wondering about using naltrexone to reduce drinking, but using cocaine when you're on naltrexone, and if there's risk for that.
Yeah, so that's a good question. I will say, number one, nowadays, I see so many patients who think they're using cocaine that's laced with fentanyl. So if you think you're using cocaine, I would strongly encourage you to find a program in your community that has fentanyl test strips, because you may be exposing yourself to fentanyl unknowingly. Naltrexone has been studied for cocaine addiction, and it just didn't work, unfortunately. Naltrexone is not going to block the high that you might get from cocaine use, but it could block, if there's any opioid such as fentanyl in your cocaine, it could block that. So naltrexone is not going to make it any less likely to that you reduce your cocaine use. And we also know that patients who are mixing cocaine and alcohol are more at risk of adverse events, more at risk of overdose. So so that's that would be my response to that.
Yeah, so it sounds like taking naltrexone and having cocaine in your system isn't dangerous. Like if you had naltrexone and then okay.
No.
Great. Well, thank you everyone for your attendance, and to Dr. Coleman for your excellent talk and overview and answers to all these questions. We hope everybody found the information from today's session very helpful. And we did provide some links in the chat, including our resource page and clinic, and information on our next session. We have one January 11th, 2023, which will be the same time at 7 o'clock. And it's focused on how to help a loved one battling addiction. And I would like to just point out that the educational series was made possible by the Patrick Gibbons Memorial Fund, which honors the memory of Dr. Gibbons, a passionate doctor who helped many people in pursuit of recovery from addiction. So thank you again to Dr. Coleman, and thank you for everyone for attending.